Hey, good morning, everybody. Thanks for joining us. My name's Ed Ricks, and we're going to take a few minutes to talk with you about improving health system cash flows through 340B program optimization and strategic management of drug spend and pricing structure. Can you go to the next slide, please? So you're going to have four of us on the panel this morning. So my name, again, is Ed Ricks, Managing Director at Baker Tilly on our healthcare consulting practice. My background prior to joining Baker Tilly was about 20 years as a CIO in health systems and a chief operating officer for about 4 years.
I'm Keith Hutchison, and I am a partner at Baker Tilly, and I am the lead in acute care reimbursement, which is an area that I've worked in for about 39 years now.
Hi, my name is Ann Jones, and I have been a pharmacy director for approximately 20 years, as well as leading electronic health records and how to optimize them to service pharmacists for about 15 years, and have been working with Baker Tilly for a couple of years now.
And I'm Sherry Faber. I am the president and CEO of 340B Compliance Partners. I am a pharmacist by trade. I have over 30 years experience with pharmacy in general, and then with 340B specifically about 15 years. And we work closely with Baker Tilly on a number of projects.
So during the conversation today, we're going to try to touch a few areas for you because we got a pretty broad program at Baker Tilly when we talk about 340B compliance and drug charging initiatives. So obviously, we'll first start with Keith talking about reclassification and participation in the program. Sherry will talk more about compliance programs. And then Ann and I will talk about how we've helped folks in different strategies to improve your rev cycle in the 340B program, and also some strategic management of your pharmacy charges. And then at the end, we're going to talk about some real world stories that we've seen have improvement for people that sort of fall into each one of those categories. All right, Keith, I think you're up, and we have a polling question.
Yeah, we're going to start you off with a polling question, a little unusual, but we'd like you to indicate your hospital's level of 340B qualification, which is A, we can look at this, I'm greater than 1175, and this is your dish payment, which indicates this. I'm over 8, but less than 1175. My hospital doesn't qualify, or I am not sure. And we're looking at this because there's different levels, different qualifications, different things you can get 340B for. So this kind of helps us throughout the program. So while you're inputting that and we're waiting for results, we're going to go ahead and get started. What I'm going to do is kind of lay some of the groundwork, just in case not all of you are in the 340B program, or if you're in it and would like to know a little more about how you get in it. And I'm just talking about today one area of qualification, and that is relating to DISH. All of the hospitals have to meet a qualification in DISH to receive, except for critical access hospitals, which are automatic. So a couple of your rural status type hospitals, sole community and rural referral, can get on DISH at 8%. But they have exclusions for that. They don't have a GPO prohibition, but they also can't take 340B as a discount for things like orphan drugs. So there's some give and takes. If you are a DISH hospital, and actually sole community or rural referral can also be a DISH hospital, but they have to meet 11.75 DISH payment percentage. Don't get that confused with what CMS sometimes calls a DISH percentage, which is before the math of the calculation. So then children's hospitals, and also cancer, I didn't put it on there, but because there's only 11 of them or something of that nature. But they have to also meet 1175, even though they're not paid DISH, they have to send their calculation in for that. So there's different levels and different levels of 340B for you. And we're going to talk on a little bit later on here on how you might change your level. Another thing I wanted to touch on that we see a lot and we deal with in the reimbursement, and that is the child sites. And that is your provider-based clinics, rural health clinics, or a unit that is not on the site of the hospital, off-site, not within the four walls. So those have to be on reimbursable cost centers. As a matter of fact, when you register them, then they require to see that they are what line, what are the expenses, what's the revenues, those kind of things. So just before we go to the next slide, I'll touch on looks like 11.75 is 29%. Between 8 and 11 is about 13%. Does not qualify is about 6%. And not sure, 52%. So that's fine. Thank you very much for letting us know that. Let's go to the next page and let's talk about some strategies. I know a lot of you have probably heard about all the urban to rural reclassifications. A lot of the bigger press things are around wage index, or you might do rural referral center to get a higher IME, but there's also a way, if you're not qualified and you meet the criteria to be rural referral center or sole community and you're urban, you could reclassify from urban to rural and become a rural referral center or sole community hospital, and therefore qualify at a percentage of 8% to get on 340B. There's many things to look at in that analysis, but you could meet that. So that's one way hospitals are getting into the program where they didn't before. If you're in that at 8%, you probably want a lot of clinic sites and those kind of things to participate at a higher level in the program. Another area that we get involved with and look a lot that we see out there in the clients is that's trying to just increase my DISH percentage. Easier said than done. But one method that is catching on out there is conversion of the distinct site unit. That's not doing anything with it physically. If your unit was on 4 East before and it's all contained and that kind of thing, it would still be there, but it would no longer be a Medicare distinct unit. It would be an acute care unit, and you'd bill a DRG and get paid a DRG rather than the inpatient site payment. So that's a method of raising your Medicaid utilization because those units are typically high Medicaid utilization. Some hospitals, if your unit's big enough, will keep the Jerry site unit at a certain age level so that the Medicare can stay on the old payment and only your non-Medicare patients are moved into acute care. That has some gives and takes because the Medicare patients that get moved in often raise your SSI percentage, which is also a factor in increasing your DISH. So you have to do some analysis with that to see which method is better and take into account, is there any Medicaid payment issues and those kind of things. But it is a method being used to increase your Medicare DISH payment and maybe take you from an 8% DISH qualifying to an 11.75, or just to getting on 8. So in the next slide, there's another method, and a lot of places do this already for their Medicaid eligible, and that's the second bullet point, which is a scrub for Medicaid eligible patient days. You typically do it and then do it around 12 months later, so you can catch any patients that weren't Medicaid qualified when you did your first and filed your cost report. You look at it and later on add it and amend the cost report, and maybe that helps pick you up. Also, you should be looking at your your total days, because sometimes those days will have outpatient days that get mixed into the inpatient, maybe through observation that wasn't really an inpatient observation and should have been an outpatient, or it picked up post-acute care days, or some other kind of outpatient days that made its way into your inpatient total. So you should always scrub not only your Medicaid eligible, but your total days to make sure you're getting every percentage point that you can. And if none of those work, then you can also do a joint venture, or if you have multiple hospitals and you're close enough to another one of the hospitals, you can have a 340B site on your campus or another hospital's campus, either through a joint venture or something of that nature, if you're related hospitals, so that you can get a 340B service at that hospital's location. We've seen that done many times with infusion centers and those kind of arrangements. So the bottom line is, you don't have to be satisfied where you are unless you're at the top and you've got everything clicking. But if you're at a level that you don't want to be at, there are ways to make it better. And that's the bottom line of this part. So at this time, I will turn it over to Sherry Faber, and she's going to talk to you about compliance.
Thank you, Keith. So some people, when they hear compliance, they think it's time to go get lunch now. So I'm going to try to make this as interesting as I possibly can. But I think I would like to drive home that we would love to present you all the financial opportunities and help you make the most of all of the opportunities in the pharmacy realm. But for 340B specifically, it won't matter if you have endless opportunities if you're not compliant, because you can be dismissed from the program if you have pretty egregious things going on. So HRSA does audit approximately 200 entities per year. And so when we start talking about compliance, you're really focused on making sure that you still qualify to be in the program to begin with, your Medicaid exclusion file accuracy, the OPACE database accuracy. And if some people are saying, I have no idea what you're saying, I will circle back to that momentarily. And then mechanisms to prevent duplicate discounts and diversion, and really just overall auditable records. And so what I broke it down to is 3 primary oversight pieces in terms of best practice if you do have a 340B program in place. I can't stress enough that even though 340B is related to drugs, it is not a pharmacy-only program. The best run programs truly have a multidisciplinary approach, and they in fact have a multidisciplinary 340B oversight committee. And you shouldn't have this meeting just for a checkbox to have minutes and be able to show HRSA that you have oversight, but rather this would be instrumental in keeping your finger on the pulse of your program. So even senior leaders, if you can participate in, typically it's a quarterly meeting, and they should be covering their internal quality assurance program, updates from an external audit, which I'll go into here in a moment. But it's a really great venue to talk about legislative updates and anything related to the 340B program in terms of brainstorming about missed opportunities. And it's really also a great place for the leadership to share future strategies. So sometimes what happens is there are great plans and there are going to be new services, and 340B unfortunately has some stringent timelines associated with registrations and when you can actually use 340B in a new location. So if that does not get communicated to the proper people who are in charge of registering new sites or contract pharmacies, then you may miss opportunity and be delayed by quite a while in some cases. So when we talk about the internal quality assurance, it's really important to have dedicated staff that are monitoring your program. And best practice is truly to mimic what would happen if you were audited by HRSA. And so the same data elements that they would test, it's helpful to be choosing a sample from all of your universes and testing each one for integrity and using those same data elements. Monthly is best practice, and I'll tell you why. So in the contract pharmacy space, many pharmacies will limit you to 30 days. If you find an error, they will not allow you to reverse it if it's beyond 30 days, which if you are beyond 30 days, that exposes you to having to pay back a manufacturer, which you really do not want to have to do that. If you can avoid that at all, because it opens up an entire conversation sometimes of, oh, you have to pay us back. Well, let's look at other drugs that you get from us and see if you have any other opportunities or things that we need to know about. So again, having dedicated staff to do these things is very important. The final point here about oversight is having an annual external audit. So I'm sure you have qualified people in place that are monitoring your program internally, but it's really best to have an external review of your program. And again, not just for checking the box and being able to tell HRSA that you had an annual review, but rather you want to be able to identify opportunities and be able to fix things prior to being selected for a HRSA audit. And if you have good people auditing, they will also perhaps point out missed opportunities that you may not have identified yourself. So that's a piece of the compliance. If we'll go to the next slide. So I do much agree with everyone that it's great to have a 340B program. You need to know how it operates and the rules associated with it for your specific designation. So as Keith alluded to already, there are different ways to be in the 340B program, and each has its own rules or punishments, sometimes as I refer to them. And so the DSH hospitals, if you're registered as a disproportionate share hospital, you do have that GPO prohibition. And then if you are other types of hospitals, you have what's called an orphan drug exclusion. The children's hospitals, that there truly are not that many in the program, they also have the GPO prohibition. But when we talk about optimization with operations and drug spend, and I'm going to keep mine within the 340B program itself, inventory structure. So making sure that your pharmacy staff understand 340B is critical. Because you can choose between what we call a virtual inventory and a physical inventory for 340B purposes. If you have a location like an infusion center or oncology infusion center that's 100% outpatient, they're all your patients, and especially if you're not subject to the orphan drug exclusion. So for this purpose, we're really talking about the DSH hospitals and children's hospitals. We can truly avoid buying the first drug at a higher cost and then accumulating behind the scenes by having what we call a clean site. And so in that regard, you can buy 100% of the drugs at 340B for all of the patients in that area. Now, certainly it's not as easy as it may sound. There are some considerations depending on if you serve inpatients at times with oncology agents. And so you have to have a backup plan for certain things. But overall, it's really a great analysis to perform to see, okay, where are we losing opportunity in terms of WAC exposure in our oncology infusion center, and what does that delta look like if we transition to be a clean site? As Keith talked about the provider-based clinics and Article 28 spaces, what this does is it allows you, you do have to fully own those, and they have to be on an outpatient reimbursable line of your Medicare, most recently filed Medicare cost report, in order to count as 340B, and then they also have to be registered prior to using 340B in those spaces. But the main savings in those areas often has to do with not just the clinic administered meds, but the prescriptions that are coming out of those locations. So you have regular contract pharmacy opportunity, or if you have an entity-owned pharmacy that you can control the overhead and costs, that's preferred, particularly with all the manufacturer blocks today. Those do not apply to an entity-owned retail pharmacy. But that one kind of bleeds over to the next bullet that I have there in terms of referral prescription capture. This is often a huge missed financial opportunity for a lot of hospitals that we come across. And it really does depend on if you own family practice, primary care, internal medicine. Those kind of providers are part of the program for you. And if that's the case, it's kind of misleading. Some people think they need to add specialists in order to capture the greater margin drugs. but it's simply not the way you should go. If you have a certain amount of money, which most people only have so much money to work with, if you're talking about converting clinics to provider-based or the Article 28 spaces, it's really preferred to bring your primary care folks over first because you can capture the specialties in a different manner. So referral prescription capture simply means that your provider saw a patient for primary care typically, and they've made a decision they need to see someone in a specialty realm. And if the case is that you do not offer that specialty yourself, but they refer it to a larger organization or even a local person that's not part of your organization, those prescriptions with certain documentation can count for you for 340B eligibility as well. And so a lot of people don't realize this is possible, or they don't have the bandwidth to do it themselves in terms of labor force. But it is definitely worth looking into. You don't really have the same opportunity if you do not have provider-based clinics or the Article 28 spaces or rural health clinic for that matter. So that's something that goes back to Keith's talk about considerations there. TPA mapping. So if you don't know what a TPA is, that is your third-party administrator, and these are the software companies that you choose to work with for 340B. If you don't have qualified people running your program, if the mapping, and you don't really need to know what that means specifically if you don't, but just suffice it to say that if this is a task not being completed, you're going to be paying a whole lot more for the medications than you need to be. Price file monitoring, I'll just briefly touch on that. Quarterly, the price files at your wholesaler are updated, and sometimes things happen. Prices go missing altogether, and when your TPA is looking for a 340B price, if there's nothing there, it doesn't think there is one. Worse, sometimes the wrong contract is loaded into your wholesaler account, and now it's splitting to 340B, but it's the wrong price. In terms of verifying Medicaid requirements, the main thing I want to point out here is that many states will allow you to choose carve in or carve out in the mixed use setting. And so that means clinic administered and then the hospital as well. However, they often have, you have to put a modifier on there to signal that they have been purchased at 340B. And sometimes they make you bill it at actual acquisition cost as well. So some hospitals will decide, okay, well, we're going to carve in Medicaid. We know we have to add the modifiers and bill at actual acquisition cost for fee-for-service Medicaid. So we're just going to apply that across the board. And what they don't realize is that some of the managed care Medicaids do not actually have them to bill at actual acquisition costs. So they're punishing themselves and actually taking a hit financially on their own accord when they don't have to. And then the final bullet before I turn it over to Ann, and this is more along her world, is in terms of billing NDCs and your charge master. So sometimes this all ties with 340B. If you're accumulating based on your billing files, if you have one primary NDC built in your charge master, and that's not even the one you're buying, you're going to be building up all this opportunity on one NDC, but that's not what you're purchasing. So again, it represents a missed opportunity in that you are not being able to purchase drugs at 340B when you would otherwise be able to. So this is just a very high level of a lot of optimization that can be done with the right people in place. But again, first and foremost, compliance has to be in place before you worry about any of the opportunities. So we'll go next to our question that we have. And so this is just to help you understand what level of consideration needs to be given to formulary choices for med classes in a hospital pharmacy if you are a 340B covered entity. And so you do typically have a P&T committee, but I can tell you from past history that sometimes they fail to recognize the reimbursement side of things. So if you're looking at a class of drugs and going to choose representation from that class, you want to take different factors into consideration. So if you'll go ahead and answer this, but I'm going to go ahead and tell you the answer. It's really all the above. You really want to take consideration into both costs, the 340B and non. 340B is an outpatient only program, so you want to know what percentage of your use is going to be in the outpatient realm. And then that whole reimbursement for each drug in that class really is a critical piece that's often missed. So it's one thing to choose the cheapest drug, but if you get zero reimbursement, that doesn't make a logical choice. So I will turn it over to Ann.
Good afternoon. I'm going to talk a little bit. Thank you, Sherry. reviewing claims for billing and compliance. This is for governmental payers as well as commercial payers. So it's not just limited to the 340B program. When I'm reviewing claims, and a lot of times I ask for 3 to 6 months. As Sherry indicated, sometimes I'm looking at validating NDCs and that they're even still active. A lot of rejections come from an NDC not being active, and the commercial payers as well as the governmental payers will take that as an opportunity not to pay you. Now, you may rework it depending on what that dollar amount is. However, it's still time spent opposed to quickly getting reimbursed for an active NDC that you actually have in stock. Also, when reviewing the claims, typically looking to make sure the HCPCS picks are maintained at the location. CMS does quarterly updates, and they also do a large annual update. With other clients, I've found that they weren't doing quarterly updates or only as needed, opposed to being proactive, which once again either causes a rejection that needs to be reworked or potentially not billed at all when it comes to your outpatient area. Also kind of look at revenue codes. So if you put a revenue code that never makes it to a claim, it causes issues. So kind of look at the claims and looking for that appropriate revenue code. Sherry touched on this just a few minutes ago. I'm also looking at the modifiers, whether it's governmental or commercial. Sometimes the two cross over. Sherry touched on modifiers required depending on the location. For 340B, they're looking for modifiers, especially for that Medicaid, but also for Medicare. G's and K's, definitely, in order to get reimbursed. They're looking for waste nowadays. And not only are they looking for waste, they're looking for what they call a JZ modifier for those single dose vials that weren't wasted. And there is a clause now that they can deny those claims, and actually seeing it in the commercial space where additional work needs to be done because of a denial. And typically, as I'm looking at files and looking at the pricing, and we'll talk about a success story in a few minutes, but also look to find out if a particular location has implemented strategic price modeling. And that is where your charges could be under what you could be reimbursed. And Sherry talked about it a few minutes ago, whether it's commercial or on the 340B side, when you're looking at calculating charges, you want to make sure, or putting something on your formulary, you want to look at the whole picture and not just 340B or commercial as far as pricing. So looking for opportunities, a lot of places historically, as a pharmacy director, would provide a straight, pharmacy would do a straight 5% across the board of all their meds, or they may specifically identify a couple of meds to increase and maybe a 3% on the others. Not very strategic. We're looking for strategic opportunities, looking all the way down to the NDC number as we look at your files. Next. So the next polling question that we're opening up is, I am confident our drug claims are accurate and all billing data is current. It's everything from NDCs to HCPCS to HCPCS quantities, rounding, modifiers. You can take a few minutes. And while we calculate that, we're going to move on to price modeling and modeling strategies.
All right,
As
thanks,
indicated.
Ann. You can maybe stay off mute too, because I'm more than happy to have you jump in here for some of this discussion too, because you lead a lot of these initiatives for us. But take the next couple minutes to talk about what can also be very impactful to the organization that you represent. And it's really around the charging that you do for your drugs in the organization. So away from the cost side of things with sort of the traditional 340B discussion that we talked about, and clearly compliance is important. And assuming that all the rev cycle stuff is cleaned up, through ongoing initiatives like Ian just mentioned, there's oftentimes an opportunity to look at the patient charges that you have in your tables in your system for drugs. And we can do the same thing. We'll go through a history of claims data so we can see what's going on. That sort of leads us into certain directions, and then we'll do some sophisticated charge modeling. And so as Ann was mentioning, this is both on the governmental side and for commercial contracts. And you may have something in a commercial contract that gives you a maximum increase of rates of, say it's 5% annually. And a lot of people will then just do an across the board increase, and they'll do that year after year after year in some cases. And it's not real strategic. And sometimes you're often increasing charges for items that are never going to be reimbursed. A lot of the oral meds and the things like that roll into the room charge now. So there's no impact to your bottom line. Your top line revenue is increasing, but you're not impacting your reimbursement. And that's really what's important to people. So there are definitely ways we can look at the modeling and help sort of maximize or optimize, I guess I would say, your reimbursement and be very much more strategic with it. And there's some tables in your HR system that we can impact so that when you actually bill these patient items, that you're across the board will be at the same level you were before. So you'll stay within your increases from the contracts, all the contracts that you have. You sort of sway things so that your reimbursable amount can go up. And it's something that we've had a lot of success with, and people don't necessarily look at things that way, and it's all based on your history, and we can project your future to some degree based on that past activity and help impact what it looks like. At the same time, making sure everything's set up right, rev cycle, that we're getting the right HCPCS codes, NDC to NDC, all that kind of stuff makes sense in there. But make sure that you have optimized your environment from a patient charge perspective. And would you talk a moment about, what an initiative sort of looks like for a normal person with this? I know this is not a sales presentation, but it just makes more sense when you hear how we literally can help people do this or have helped people do this.
Sure, right, thanks. Typically, we start looking at your claims data. We're reviewing the charge master file, as well as markup tables, different EHRs, utilize different methodologies. So we're kind of agnostic, and we look holistically at those charges. There are certain data fields that we look for in that file. And then we actually create a map to, if we move some things around in a bucket. So if you have 6 months worth of data, it's best to predict with high confidence levels, very high confidence levels. If we move some buckets around, create a new buckets as far as charge master tables or markup tables, and then we take that information after all the mapping is complete, and we input it into a database. We're able to visualize if we make all these changes, if we move from using WAC for our commercial payers to AWP or to GPO, or however a client wants to look at it, and push those claims back through, as well as adjustable markup tables. We can give you a visualization of what that impact is. We could do one line, we could do all types of changes, all four, by payer, by cost, by markup tables, identifying undercharging, etc. They may be occurring, and working with your revenue cycle, and especially with the pharmacy staff, to understand their trends so that they can also make informed decisions with that data. but it's using a client's actual information and discussing with the pharmacy to understand if any additional services are changing so that you can strategically price items based on data opposed to how you feel about something.
Thanks, Ann. And I see we got, the polling results back. Sherry, you probably gave the spoiler alert too early. So most people got that one correct. Most of these don't have a right answer or not, but that one certainly did in question number 2. Number 3, it's really interesting, and thanks for being transparent and honest. I think that a lot of people have some sort of program in place for sure to monitor activity and try to reduce the amount of denials that they're managing based on these charges. But we don't always see people with really mature programs around that and keeping that ongoing. So it's just like compliance is equally as important. They're all different elements of a good, robust program in an organization. All right, I think we can go to the next slide, which is another and last polling question. So in your organizations, is your drug pricing methodology reviewed and optimized for governmental and commercial payers? And, just do you have a robust internal process? If you have a process, do you sort of analyze across all payers that are relevant to you? And do you normally, and probably some of these people could answer more than one of these, but, just pick one. Do you do across the board rate increases for drugs every year or not at all? And then we've reviewed the pricing strategies for a few years or haven't. And then, of course, if it's an NA, go for that. And now my favorite part, we're going to go back sort of in order of the way we just talked through, because they're all very distinctly different parts of a robust 340B process of an organization or a drug charging process. But talk about some real world case studies. I think that's the most relevant thing and where we've seen people have success. So Keith, can you please talk through one on a classification or reclassification?
Yeah. Without disclosing any kind of client name or information, we have worked in the reclassification, but the most interesting ones to me have been the changing of a unit within the hospital to get more Medicaid days in the acute care. And it really takes more than just a look into 340B, because when you move those beds from a distinct unit into acute care, well, that'll affect the indirect medical education calculation, because more beds equals a lower payment. So you have to take that into account. So it's a holistic view. But we have been successful doing that and getting everyone involved to take the pluses and minuses, because the overall impact at one particular system with multiple locations was in excess of $10 million net of any good or bad. And they were able to do that because they had everyone involved and everyone could see that the overall impact was for the good of the organization, including they even did a couple of the items we discussed when in my part of the presentation. They also put a site on another hospital's campus that was theirs to do infusion. So it really was an overall win for the hospital, but it took multiple units of the hospital to work through it. It can't be done in a silo. So there are a lot of ways to go. We've used the psychiatric conversion multiple times in multiple states with success. So there are a lot of things you can do. We've reclassified the hospitals because, like I said before, if you reclassify to a rural referral center, you not only get 340B at 8% dish. But if you have education, you get a 30% bump into your IME cap. You can get a better methodology for reclassifying for wage index. And who knows, you might even benefit from a rural wage. So there are a lot of factors in each one of these. But if you properly plan it out, they're very successful.
Thanks. I mean, I would just find that incredible. You know, as a CIO for all those years, we definitely participated in the 340B programs. But I didn't even realize that there was the opportunity to sort of reclassify by moving beds where appropriate and looking at all the what if scenarios, you know, and picking the best one at some point in the future. And those kinds of dollars are impactful to organizations these days. So thanks, Keith. I appreciate it.
I'm always impressed that hospitals in New York City can be rural.
Yeah. That's an accounting tool in there somewhere, I think, but
Yeah.
thanks. Sherry, I know you've got some great stories to tell around compliance success in the past.
Sure. So generically speaking, it's often we come across organizations, I mean, they just don't know what they don't know. And so when you start digging into and telling them, hey, you really need to be looking at replenishments, you need to be able to look at this, and they suddenly realize, wait a minute, somebody's keeping our money. We're paying on replenishment, and this is just sitting here. So that's a generic piece, but I can give you a great example of the opportunity that I shared related to having a physical inventory in oncology, for example. So we have a health system that we work with, and they had not really thought about doing this. And so when we were actually on site for a mock audit for the 340B program, I try to mention any opportunities that we can think of. So we entertain and explain how they could potentially consider creating a clean site because they carve in Medicaid and create the ability to buy straight 340B and not have the WAC exposure on the first purchase, and then making sure the billing's all in line so that you're not delayed in accumulations and so forth. And when they ran the numbers, they were rather shocked to see that it was going to save them approximately $500,000 a year by simply changing that model. Now, that's certainly, I will admit that any kind of hospital with an oncology infusion center, you do have to give consideration to service of your inpatients. And so there is a piece to consider that you may have to have a small inventory, also a physical inventory of GPO for inpatients only, but that should be a very small subset. But the savings opportunity overall makes it worth the while. If you have a robust infusion oncology center in a DISH hospital or children's hospital, in my personal opinion, it's just phenomenal what we've seen when people do that. It is a little labor effort, but I don't think most people would not consider $500,000 to be something they would be willing to just leave on the table. So,
Yeah, it makes compliance more exciting than just
right.
lunch or whatever, right? For sure. Yeah, that's very impactful for anybody. Awesome, thank you. And Ian, before we jump to the next one, I see the last polling question came through, and I don't know if there's anything super insightful. And again, I appreciate it. This is pretty much what we see across the board, that a lot of people have some sort of program in place and consider strategic pricing improvement annually or regularly, but not everyone does. And never hurts to have a little tune up or have someone look at that a little bit deeper and look for opportunities for optimization for you. All right, Ian, these last two, I mean, we can go through these together because generally they go hand in hand. But do you mind talking through a good success story for rev cycle and pricing improvements? You're still muted, I think, Ian.
Yep, not quick enough to go off mute. Sure, Ed. Yeah. I was kind of looking at the polling question that was just talking about denials and confidence levels. And what's kind of interesting is there's about 64% of the respondents had some question or maybe something in their gut saying, hey, I'm not completely sure if everything's looking good. That is the same space as one of our success stories. We actually had a new CFO that came into an organization, and he was like, I want to take a look at this space, this pharmacy space, for a multitude of reasons. They were a 340B location, but they also had some commercial. And he was like, I think we ought to just do an independent check. You know, we know we want to move some pricing around. We feel that we're undercharging in some areas, or I do. And can you take a look at that? And so we started digging into that particular client, relatively small hospital. But there were big things there. Once we started looking through the files, and they said everything was good, but we just did an independent check. And then we did the price modeling, or found an opportunity first by looking at the files that, yeah, they probably need to be tweaked. Once we started looking into it, we found in the end about, I think, 14 million in gross charges. And in the end, working with the CFO, they're estimating, I think it was about a 3 million net. Was it 3 or 4, I believe?
Yeah, for that organization, the CFO validated that was between $3 and $4 million, bottom line net.
Yeah.
Change. And again, just by catching things and managing them differently than they've done in the past around pricing initiatives and certainly some of the rev cycle improvements that they went through the process. Again, impactful for everyone. And all these organizations, I feel like already do a good job of looking for opportunities.
Absolutely.
So this is sort of over and above what people generally come up with. And that's what's interesting about it. Most of the initiatives that we work on, it's really to help people drive some sort of improvement by reducing cost or improving the bottom line of revenue. That's a great story. All right. I was just going to ask if we have any questions. Wow, this is going to take someone way smarter than me to answer. Can you guys all see the question? Does utilizing 340B supplied medications have a negative impact on prescription benefit premiums as the covered entity collects the federal rebate portion, eliminating the pharmacy benefit ability to collect their rebate used to lower premiums? All right, that's a lot of silence from the experts. So I am not, honestly, I have no idea how to answer that question. I don't think there's any impact on premiums on the insurance side. And certainly 340B is going to be governmental. So I'm not sure how to answer that question. I'm sorry. We will share our email at the last slide here, I think, or it's got all of our demographic information again. And so, Henry, if you don't mind shooting an email to me, we can sort of follow up, I think, because maybe there's more to that question than what I'm catching.
Yeah, I think it's far more complicated than just a short answer. That's why.
Yeah, the answer is maybe, but no. I think that's true. I'd love, if there are any other questions, please, we'd like to try to answer anything. But if not, we thank you so much for joining us and appreciate you staying on board through the whole conversation. And thanks to Sherry, I've been ready for lunch for like 45 minutes now because you mentioned that. But thank you again. Thanks for joining, and I hope you guys some benefit from the presentation.
Thank you.